Good morning, Chairman, ladies and gentlemen. Today is the 19th of May. It's a very special day. Anybody know what day it is? Dr. Kas, I don't know. Today is the World Family Doctor Day. And it is a very meaningful day for us, and especially so because we are here together with doctors from different countries talking about something that's very important to family medicine. And I would like to express our gratitude and thanks from our Singapore colleagues to the organizers, to Japan Primary Care Association, to our colleagues from Korea and Taiwan for inviting us to join this four-country meeting. I'm Dr. Kheng Hock. I'm the president of the College of Family Physicians, and I do many things, including teaching family medicine. I changed my whole PowerPoint slide. That's why I slept very late, 2 a.m. I wanted to tell you all the details about our program. But as I was thinking, because we are undergoing tremendous change in our training system in Singapore, so what I tell you today based on my old PowerPoint slides will be quite irrelevant. Because we are changing the system, because we are now facing a crisis in our country, and we are now going back to very fundamental questions. Why do we train to be family doctors? What do we train them for? How do we train them? How do we know after training they're actually good and helping our patients out in the community with all their problems? And then if we follow our plan through, how do we know that it has all happened for the right reason and for the right cause? So these are very fundamental questions, and sometimes I feel very sad because when I interview trainees or residents, they tell me they want work-life balance, they want to do this, they want to do that, but I think at the end of the day we must ask, what is your mission and why do you want to pursue family medicine? I think that is a very important thing. And sometimes when we change all the programs in a very complicated way, we are actually trying to adapt it to our different countries. So you'll find that every country will have a different system, but there's a common theme, and the common theme is the principles and the cause of family medicine. Sorry, I think my slide is not moving. Sorry for the technical. Okay. So I think it all started when medicine started to specialize back in the 1940s. So we must ask, why do we train? What is the origins of family medicine? And that's how it all started. Back in the 1940s, everything started to specialize. And you can see what is politically correct today will be so incorrect tomorrow. And this in the 40s, it was even fashionable to get doctors to advertise for smoking. And you see doctors wearing coats, looking at microscope, basic science, and that's the enchantment with specialization started. And so family medicine actually is actually a response to this. And it's a global phenomenon, but I think it was very well captured in the United States, where the people rose up from the ground and say that they are not happy with the state of medicine today. They lost the doctor that they wanted and they had in the past. A holistic doctor who takes care of the patient as a whole, who doesn't specialize in organs but specialize in the person. So back in the 60s, I think the late 60s, there was this mass movement from the ground to say, give us back our family doctor. And I think Professor Robert Taylor summed up very well. He said that the initial promise of family medicine, and the emphasis is in the word initial promise. The initial promise of family medicine was that we would rescue a fragmented healthcare system brought on by the specialization which started in the 1950s, put it all together, glue it back like a broken vase that was once very beautiful, and then return it back to the people. And so we really have to ask ourselves, have we really achieved this initial promise of family medicine for the people and the patients that we serve? Next slide. So just a quick introduction of how family medicine is in Singapore, so then perhaps you'll understand why we are changing the mission. So Singapore's primary care is divided and served by various clinics. There are 18 government clinics and thousands of private GP clinics, and they work independently, independent from one another, and independent from the hospitals, and everybody just go about their business. 80% of the primary care is delivered by the private sector, the solo GPs, and only 20% is by the public sector. Next slide. And then for hospitals, they again work under a separate, totally separate system. We have 29 hospitals, 13 public hospitals, 16 private. There are essentially 5 major hospitals in Singapore. These are our flagship hospitals where all the repository of knowledge and skills and expertise reside. They are the Singapore General, Tan Tock Seng, NUH, Changi General, and Khoo Teck Puat Hospital. So those of you who have visited Singapore would usually make a visit to one of these 5 hospitals. Next slide. And then we have intermediate and long-term care. We have community hospitals, nursing home, hospice, home-based nursing, hospices, day rehab centers, daycare centers, and so on. Next slide. So we are now undergoing a change, and we say that everyone working busily by themselves is not effective. We have to work as a system. So we have therefore grouped everybody together in Singapore into 6 to 7 clusters. One of them is just forming. And each of them is centered around a major hospital who act as a nerve center. And we bring together community hospitals, day services, rehab centers, hospices, primary care clinics into the common umbrella. And we are now in the process, like I heard in Taiwan, to bring the private primary care into the fold and make them work together as the whole regional health system. Next slide. So one of the big cluster is where I work, that's the Singapore General Hospital. We call it the Singapore General Hospital Campus. For Singapore standards, this is the largest hospital. We have 1,700 beds, 36 specialties, of which family medicine is one of them. Large numbers of patients moving in and out. It's a very busy hospital, but we are very dissatisfied with the way we are working because while our doctors are good, our people are very dedicated to their job. They go home very late. They put patients first. Our tagline is that patient at the heart of all we care. But we find that we are very ineffective and we are very frustrated because whatever good work that we do in the hospital, the moment they move to the next point of care, it becomes totally unraveled. And then back to square one, it's like going 2 steps forward and then 1 step back and 2 steps forward and sometimes 3 steps back. So it's a very frustrating thing for our colleagues working in the system. So we are changing and we say that we need to change. And everyone has seen this pyramid, the triangle, and everyone say it's upside down. And it's true, it's upside down in most of the countries, especially when primary care is either undeveloped or if it's developed but not integrated into the health system and it functions like a narrow base in a triangle. So for us, we have decided that we need to put all these components in a triangle into a regional system so that it remains stable as a triangle. So in Singapore, we also have tsunami, but it's not the real tsunami. We call it the silver tsunami because our patients are growing old very fast. And it's a tsunami in slow motion, so it allows you into a sense of complacency. Nobody is running away from the tsunami. But when this silver tsunami hit our healthcare system, we are very sure that it will totally destroy our healthcare system, which is why in Singapore we are beginning to raise the alarm and try to change the system. And to change the system, we also need to change the training. And family medicine or primary care plays a very key role in this system change. So we have 4.7 million people squeezed into 660 square kilometers. And our population is aging very rapidly. And as you can see from the graph, life expectancy is also very high. Singapore's total fertility rate is below replacement. It is actually one of the lowest in the world, even lower than Japan. I think Japan is 1.39 or Singapore is I think only just 1.0 something, 1.02 or 1.2. So we are not producing enough people to replace, and this will cause us many problems. Next slide. So the population is older, they have chronic diseases, they get complications, and the care becomes very complicated. And this graph tells you the future. So Singapore, we're always very proud. We say that our GDP spending is very low. You can see the little red dot that we are is always way down on the scale. And the United States, of course, is way up on the scale. And we like to laugh at the US and we are very proud about Singapore. But actually, when we look at this graph, we will realize that we should not be too complacent because we are low largely because our population is still relatively younger than many of the developed countries. And you can see that if you take the ratio of dividing the people above 65 over those who are below 65, and you will realize that there's a relationship between healthcare expenditure and this age dependency ratio. And we are very sure that as our population ages, and we ages like a silver tsunami, that in no time we will speed right across to the right side of the curve, which is why before it hits, we are making serious changes to the system. Next slide. So, and then this is the phenomenon we are beginning to recognize. We are running our hospital beds. Emergency attendances, admission to hospital are rising at a constant pace, and we are constantly have a situation where we are extremely short of beds all the time. Next slide. Next. So this is our Singapore's health minister, and our whole country now is talking about silver tsunami all the time. And our leaders are wise, and they really try to do their best for the country. And to a large extent, our people still trust our government. And he said that, however, building more and more hospitals is not the solution. The private sector delivers, as I told you, the majority of primary care. And we are trying to develop new models of care. We are changing the whole system. We are trying to encourage them to form groups into family medicine clinics. And in the last sentence of this quote is very crucial. He said, we are also developing more options for seniors to be cared for in the community through home care services and better caregiver support. So we are developing this whole system change for us to meet this silver tsunami crisis. Next slide. Next. Okay, so we believe that everything needs to be integrated. The polyclinics, the family physicians in the private sector, the acute hospitals, everybody needs to work together into this and putting the patient in the center. And because the patient will move in and out of the system from one setting to the next, everything has to be seamless. Next slide. Back one slide. So the patient needs to go to the acute hospital, to the community hospital, to the nursing home, to the senior care center, to the GP family clinics, to the most advanced national specialist center. And he moves around this whole ecosystem of the healthcare system. And all these components have to work seamlessly like a network. And we are trying to develop all of them into regional health system as a network of partners. Next slide. Next slide. So this is the latest issue of our college newsletter. It was written by Professor Cheong Pak Yen, our past president, and he really sets the tone for family medicine. We realize that we have a new mission. We are all one discipline, but we work in many different settings, just like as I've noticed in a similar situation in many countries. Some of them work in the hospitals, acute hospital, tertiary hospital, they work in the universities, they work in community hospitals, they work in polyclinics, they work in GP clinics. But we all train under one discipline, and the underlying thing, despite the different settings that we practice, is that we subscribe to the principles and the practices of good family medicine. And this is the thing that unites us, although we may practice and study slightly differently in many areas. Next slide. So we believe we have to integrate the care of the patient, and family medicine physicians right now in Singapore are doing a lot of this care integration service because care is so fragmented, there is no specialty who can do this job. The gastroenterologist can't do it, the nephrologist can't do it, the surgeon can't do it. Even the geriatricians can't do it because not everyone who needs this kind of care is above 65. There are younger patients with complex care needs as well, children with severe disabilities and so on. And family doctors are the ones that are most system-based enabled. And we really truly believe in the concept of system-based practice and putting patient at the center of care. So we realize that family doctors are the doctors and the discipline who can meet this challenge. And therefore, we are placing a lot of emphasis in training our family doctors to gear them towards fulfilling this role. Next slide. So this is another example of another activity that's going on. Multidisciplinary care is very important. The busy family doctor working with a team of case managers, nurses, social workers, all come together. And this is one of the new projects that we are developing in Singapore under my department. We are testing out this system where we identify high-risk patients of readmission, and we introduce multidisciplinary team care led by family doctors to try to integrate the care and bring them back to the community and watch over them as they stay in the community and try to ensure that they are continue to be taken care well by our partners in the community. And we are doing a randomized control study to make sure what is our effect and how we can improve the model further. Next slide. And we also do transitional home care. Patients who leave our hospital are in such a complex state, it is very difficult sometimes for the primary care to take over completely. So from our hospital, our family physicians go to the patient's home with the help of our nurses and case managers, and we try to improve on the discharge planning and try to link them to our primary care partners in the community. Okay, next slide. We also do many things in the hospital. Our family physicians chair hospital integrated care conferences. We bring our colleagues, specialist colleagues in and say, can you bring this complicated case to this conference? There we have case managers, we have social worker, and we have our family medicine-led multidisciplinary team. And we try to say that how can we help you to bring your patient safely into the community? And we help our specialists to do better discharge planning and better care integration. Next slide. And we also are advocates for advanced care planning, which is so important as our patients accumulate increasingly severe disability from their chronic illnesses. Next slide. And we also help a large team of case managers who look to family medicine department and the family physician for leadership in helping them piece together the medical aspects of the care that they need. So we work very closely with our large team of case managers in our hospital. Next slide. Next. And we also connect to our GPs in the community who are affiliated to our restructured hospital. And we have this program called Chronic Disease Management Office that helps to improve chronic disease management in collaboration with our GP partners in the community. Next slide. And then we have community hospitals like this, where family physicians from our hospital send a team to provide the general medical care for these patients. So as you can see, there's this good-looking gentleman with a red tie that bears some resemblance to me, surrounded by very lovely ladies who are nurses, the multidisciplinary team, social workers, and some of them are my team of colleagues. And we feel that as family physicians, we have a great contribution to improving the care in community hospitals such as Bright Vision Hospital, which is part of our regional health system. Next slide. And we also link up with our community partners. Next slide. Next slide. And so our strategy is to engage, and we say we work closely with the Ministry of Health and the university, and we create our program. Next slide. And we enable our doctors to train at their own pace. They can go through a 3-year residency program and end up in the middle with the Master of Medicine, Family Medicine. And for those who want to teach and take up leadership role and make up and do more, take up more complex type of cases, we encourage them to do an additional 2 years where they exit with a fellowship of the college. Next slide. And we evolve because we believe that we need to change our training to meet the needs of our patients and our community. Next slide. And we benchmark ourselves. We go to the Australian College and say, can we understand how we can be better? And let's benchmark our standard to your standard to make sure that we do not slip from our standard. So we have reciprocity with the Royal Australian College of General Practitioners. Next slide. And we like the American system, the very structured way of training, the competency-based training, the assessment, and the focus on getting outcome. So we discussed with the ACGME, and they have agreed to accredit our residency programs, and we are the first country outside the US to have this ACGME international accreditation to make sure that our programs continue to be of high quality. Next slide. So, next slide. So we form committees to oversee this transitional process called the Joint Committee of Family Medicine Training in Singapore. The next slide. And we have 3 residency programs run by 3 clusters who have medical schools attached to them. And these residency programs are always accredited by the ACGME team from the US that comes down together with our own internal auditors to ensure that our programs are training according to the requirements and the competency that needs to be developed. The next slide. This is another program. Next slide. And this is the 3rd program. Next slide. Next slide. So this is a typical training program. As you can see, it's not very different from any other program. They go through adult medicine in blocks of 3 to 6 months, adult medicine, obstetric, gynae, orthopedics, family practice. And in year 1, year 2, year 3, it goes through this rotation. It's very similar to a typical US type of residency. And before entering the residency in family medicine, we require them to do a transitional year in the PGY1. So they all start at PGY2 and enter our program. Next slide. So actually, we need to put everything together. We need to understand what is the goals that we have in training our family doctors, and we must determine the competency, what do they need to learn and what do they have to understand. Then we create the curriculum and we assess, and finally we must always look at the outcome. So we must always change. As the goals of our training change, so must the training system change. Next slide. So this is the new mission for family medicine in Singapore. Maybe some of it may be relevant to the different countries. There are technical challenges, having common registries, the EMR, partnership agreements, finance models, and so on. But technical issues are easy to solve because they require technical solution. But more important is the cultural challenges and the cultural issues. And as we all know, the medical profession is a very powerful force in the society. Sometimes we are very silo in our thinking. Even family medicine, as we criticize the rest for being silo, if you reflect on our own issues, sometimes we are also very silo. We don't want to change. We always think that the old system was better than the new system. But if we want to be truly patient-centered, our training and our thinking for training must also be patient-centered and also community-centered and system-centered. Next slide. So I've come to my end of my presentation. I hope you have understand a little bit more about the Singapore's changing system, and I hope that in the future I can come and report what we have achieved in the next 3 or 5 years, which I think will be a very exciting time for us. Thank you very much.